In today's video, we're talking about radiation, and we're talking about the rectal wall and the prostate and these new technologies that they have out that are spacers, where it separates the prostate away from the rectal wall in order to prevent radiation burns. Now, radiation burns, there's a really low percentage with modern radiation, but they're still really severe for the patients who get them. So this is really just an awareness that these products are out on the market, and today we're going to talk to Dr. Mark Schulz, who's a 30-year medical oncologist who's focused solely in prostate cancer, and we're going to talk about the plus and minuses of getting these types of injectables. Today we're talking about spacers when it comes to the rectal wall and the prostate, and this is in regards to radiation. Now, there are different types of spacers. The original one was called SpaceOAR, and that was the first to market. I remember back probably about 7 or 8 years ago it was coming into fruition. But now we have a couple more on the market, and we wanted to give an update and also let people know about some kind of, caveats and some things that they should know about in order to be aware as they go through this process if they so choose it. So first of all, can you explain just what a spacer does when it comes to radiation?
So when we get radiation to our prostate, the doctors ideally would like to extend the radiation about 5 millimeters or so outside the capsule of the prostate to ensure that all of the cancer gets covered. If the cancer is often, as it often is, up at the edge of the gland, it can sneak out a little bit, a couple millimeters. This is one of the advantages of radiation, is you can spray a little bigger margin than a surgeon can do, who has to just cut kind of right on the edge. And sometimes we'll leave cancer behind as a result. So the rectal wall is within millimeters of the prostate wall. And historically, when they gave radiation to the prostate with this 5 millimeter margin around the outside, they were saying, okay, we're going to incorporate some of the rectal wall in the radiation field. And as long as not too big an area of the rectal wall is included in the radiation field, we've learned through experience that the rectal wall almost always can tolerate that. So this all requires great precision and planning and whatnot. And before SpaceOAR came along, the incidence of serious rectal burns, we call it proctitis, was pretty low at centers of excellence, maybe a couple percentage points. But still, if you were in that 1 out of 50 patients, you could end up with a burn that never heals. And so you're thinking about the horrible radiation and what it did to you for the rest of your life. And then if you're not at a center of excellence, the incidence of long-term proctitis would be even higher. So these devices are designed because the rectal wall doesn't stick to the prostate surface. So if you can put something between the rectal wall and the prostate surface and move it away from the prostate surface, then the doctor who's giving the radiation can be even bolder and putting a little bit bigger margin, and he doesn't need to be as concerned about potential damage to the rectal wall as the dose of radiation goes higher.
Now, can you just describe what a rectal burn is, how it feels, and is there any cure for it?
So there's different degrees of rectal burns. The worst of the worst is where the burn is so bad that it creates a hole, they call it a fistula, where there's a connection, say, between the rectum and the urinary tract. I don't know that I've ever seen that, but I've heard it described, and it's certainly a disaster. The types of things that I have seen is, a burn is, everyone's familiar with that. There's inflammation, redness, pain, sometimes bleeding, and this is a, constant discomfort that's exacerbated every time someone defecates. It's an ugly and dreadful proposition. Now, short-term irritation of the rectal wall, short-term proctitis for a few weeks, up to a month, 6 weeks after the radiation is something to be tolerated, and it usually heals up on its own, and everything is fine. But what we're talking about is a small percentage of patients in whom it doesn't heal, and the ongoing discomfort and bleeding can be forever. And that is an ugly proposition. What can be done for it? To some degree, people will respond to hyperbaric oxygen. It's where people are put in a compression chamber for an hour a day for a month or two. Sometimes that will promote healing. That doesn't guarantee a complete reversal of the problem, but it may help. But many people with this problem just have to learn how to live with this deficit when it occurs for the rest of their lives.
Before I get to my next question, I just wanted to remind you that in September we're having an in-person prostate cancer patients and caregivers conference. It's a great way to get your questions answered by world-renowned prostate cancer experts. Also, please subscribe to our YouTube channel because it's a great way to support what we do and get our videos out to people who need them. And if you would like to donate and support our cause, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. Even with modern radiation being as good as it is, because comparatively we saw more radiation burns, in the past with former versions of radiation, and now with new forms of imaging and all the technology that they have, there's still a 2% risk that there's the possibility that somebody can get a rectal burn, which I think, like you said, even if like a 1 in 50 patient gets it, that's a consequential lifelong problem. So I hear this argument from some doctors who are giving radiation and they say, well, my percentages are super low. Well, the idea is, yeah, but what if you're that patient? So how do you handle or encourage patients to talk to their doctor about it if they are hearing my percentages are low, you don't need to worry about it?
All doctors think that they're great, and they're not necessarily very objective about how good they really are. And there's no doubt that there's a spectrum of quality out there. And this is one of the biggest challenges that prostate cancers face on all fronts. How good are they if they're a surgeon at not making you impotent or not making you incontinent? No one's perfect, but certainly others are better. The reassurance that I'm really good and that this isn't going to happen is, to me, not a very compelling argument. The other thing to consider in this whole process that I think has increased the attractiveness of these spacing products is the growing popularity of something called SBRT, where instead of giving small doses of radiation daily over 4 to 6 weeks, larger doses are given in 5 visits over 10 days. Without this sort of protection, the incidence of rectal burns goes up when you give the radiation that quickly. And it's a much more popular and convenient way to give the radiation, i.e. over 10 days instead of over 6 weeks. That increases, I think, the demand for some sort of device to protect the rectal wall, especially when we're thinking about doing SBRT.
So we've talked about IMRT, SBRT. What about in situations with brachytherapy? Would you find that a barrier would be helpful?
Yes. So brachytherapy is a somewhat augmented dose of radiation compared to what proton and SBRT and IMRT are accomplishing. And if, as is often the case, the tumors do tend to be near the rectal wall, you want to ensure full doses to the tumor with an adequate margin. Just relying on the tolerance and saying, well, we're not treating that big an area of the rectum and most people get away with it, to me seems unsatisfactory if we have a safe way where we can take the rectal wall out of the picture altogether.
So getting into the details, we have Spacer, which has been on the market, I think, for about 7 or 8 years now, maybe a little shorter, give or take. And then we have Barrigel, which just came out about 2 or 3 years ago, and now we have BioProtect, which is actually a balloon, Spacer and Barrigel being an injectable. So can we just start with the injectables really quick and talk about the process of getting that before you would get radiation?
Men are getting radiation in 2 different situations. One is if they haven't had any previous treatment. That's the most common situation. And then there are men who've had previous treatment of some sort. Maybe they had HIFU or previous radiation or surgery or whatever, and now they're coming back to get more treatment to get rid of something that wasn't eradicated the first time. So if you're talking about the virgins, the ones that have had no previous treatment, the men that utilize Spacer or Barrigel are put in what's called a Trendelenburg position, where they're kind of like a man about to have a baby, so to speak. The doctor's working underneath the scrotum, but above the rectum, and inserting a needle between the rectal wall and the prostate. It's done a little differently with these 2 different Barrigel and Spacer technology, but there's more similarities than differences. Once a needle or a guide is advanced into that space between the rectum and the prostate with Barrigel, then they slowly inject a biopolymer substance that expands that space and then is going to stay there for several months. The doctor has an ultrasound in the man's rectum, and he can sort of see and put the Barrigel where he wants it to go and observe how much is there and where it goes. Spacer is slightly different. Once the space is achieved, they squirt water in there to create a pocket in the desirable proportions that they're interested in. They quickly insert the spacer gel to fill that pocket that was created. So these are both effective. Comparing the two, there are a lot more similarities than there are differences, maybe minor differences. Supposedly, Barrigel is achieving a little bit wider spacing than the spacer is. Spacer is popular because it's convenient and quick. The other, you're injecting it more slowly and kind of feeling your way forward. It seems like the spacer might be a little bit less deformable than the Barrigel is. The Barrigel is a little more plastic, so if you squeeze it or have a big bowel movement or something, it can distort the pillow that was created to a small degree. These things are all kind of minor issues that doctors can work around and work with. They're both effective products. There are occasionally problems with a spacer. If it gets injected into the rectal wall, you could have some what's called necrosis of the rectal wall, and doctors need to be aware of that and make sure that this isn't happening before they march along into doing radiation. But again, I would reiterate that it's something where the experience of the doctor using the product is much more important than which product is selected.
Can you define what necrosis of the rectal wall is for the patient?
I think of it like an ulcer. If someone had an infection but no inflammation, no redness, no tenderness. It's just an ulceration of the rectal wall.
When we're talking about, using a needle and they're in that position, is it medicated? How big is the needle? Is it in the perineum that they're putting this, needle in?
Yes, definitely in the perineum. The needle is not a broad gauge needle. Typically, people are medicated with Novocaine. Sometimes doctors will put people to sleep for it. It can be done either way.
And how long does it typically take to administer?
Well, a very skillful doctor putting spacer can put it in 10 minutes.
And then as far as the radiation goes, do you go straight from having a spacer put in and then straight into radiation? Do they usually send you home for a day and you come back?
It can be done both ways. The spacer stays in your body, as does the Barrigel, for 3 to 6 months. And so there's no urgency to do this the same day. And there's also the freedom to wait a few weeks if that's needed.
So what about getting rid of the spacer? I mean, if it's staying in your body for 3 to 6 months, is there any issues with either patients, how are they eliminating it?
So it dissolves on its own. This is, I think, the breakthrough of these products is they've figured out a chemical substance that will stay stable for 3 months and then start to dissolve spontaneously thereafter.
So are there any issues in just normal human bodies with having a chemical put in? Is there any sort of issues that you've seen patients have, even if it's a small amount of patients where maybe they don't take it well, maybe their body doesn't like it, they're allergic? Is there any issues within that realm?
I would say the biggest thing in talking to doctors that are doing radiation and who say some patients have complained that they can feel the fullness in their rectum, and in some people it affects their stool habits and patterns. Feel like there's sort of a bump back there that they have to get around, but it's not typically a big deal.
So one of the questions that has come up from patients is they've read different studies and heard doctors and physicians talk about it, is that it can possibly distort MRI imaging. Is this a big issue or something that you can get around, or is this something that patients need to know about when it comes to getting a spacer put in and maybe their MRI is coming up and they're wanting to see how the radiation did?
I don't think it distorts MRI imaging. I think the issue is if the pillow can shift, then the targeting when you're going in, let's say daily for 6 weeks, needs to be adjusted. The finest centers have ways where they'll recalibrate and target every time you come in. But some centers will only target once a week, and they'll just assume that the configuration is going to stay stable through that week. So if there's a deformation of the pillow, that's going to move the prostate a little bit, and the accuracy of the radiation could be diminished if that is not compensated for.
So would you say it's true that patients really need to pay attention to getting these spacers when they may be looking at community centers, because they are not centers of excellence who may be, they may have a lot of practice with these spacers and may have lower rates of rectal burns due to the fact of how much radiation they do, where maybe a community center that may be local and in their area will not have as much practice?
Yes, I agree with you that this helps compensate for doctors that maybe aren't totally on the top of their game, and I think it will save some patients from rectal burns that would have had rectal burns if they didn't have a spacer or a Barrigel or a balloon placed. The interesting thing is that many of the centers of excellence still routinely do use these, even though they're very, very good. No one's 100%. And centers that are doing this a lot and are very practiced at it and really know what they're doing, and it just becomes a part of their usual protocol. The incidence side effects from the administration of this is very low, and the confidence that they have then to aggressively provide a treatment plan that covers the posterior wall of the rectum thoroughly with radiation to ensure I think one of the biggest disasters with radiation is to have someone say they had radiation before and now it came back in the prostate. That is an ugly and difficult proposition. Do we have strategies for that? Yes, but it is far, far better to never have to face what we call a local recurrence. And the thoroughness and the aggressiveness of the radiation is partly predicated on the confidence the doctors have that they can deliver full doses to the posterior part of the prostate.
So there's a new product on the market that is not an injectable, but it is a balloon called BioProtect. Can you explain what this product is?
So it's a little different strategy to accomplish exactly the same thing. That is to move the rectal wall out of the radiation field, move it away by putting something that's a spacing device. In this case, it's a biodegradable balloon. And of course, it's designed to be the right dimensions and length. This is also inserted through the perineum, just as we described with the gel, only they create a little bit bigger pathway, something that sort of stretches that out, and then this collapsed balloon is put in an introducer into that space between the rectal wall and the prostate. And then it's filled with saline. And it expands. The advantages of this device are that it seems like the spacing is even greater than what can be achieved with the gels. It can be deflated. You asked earlier, how do you get the gel out of your body? Well, you wait. In people that find the balloon uncomfortable, it is feasible to have another procedure and have it deflated after the radiation is done if it's creating problems. It does require a procedure to do that, and it's not routinely done, but it is available. And that might partially relate to the fact that since it is bigger, there is probably a little more awareness from the patient. We talked about there being a bump in the rectum with the gel, and it's probably felt a little bit more. Also, since the way the device is introduced through a little bit larger area, people would tend to have a little more soreness after the placement than they might with one of the gels. It's, I think, a nice new alternative, and speaking to some experts about this, they're particularly encouraged by the fact that the spacing at the level of the apex, which is a sensitive area, ideally doesn't get radiated very much, that this pushes the rectal wall away in that area, and they find that it's functioning very nicely.
So does the balloon stay there, or does it actually degrade over time?
So the balloon material is biodegradable. So if it isn't deflated, which it usually isn't. Usually it's just left there. And after a few months, the body starts to break down. It's not plastic. It's something that the body can digest, so to speak. It just takes a few months to do that. And then the water that's inside just gets absorbed into your system. The whole thing ultimately is reabsorbed and there's nothing left behind.
In a matter of hierarchy, is one spacer better with some type of radiation than another? Are they all kind of equal, you would say? How would you say to a patient who's trying to decide between these three if they have the option, or maybe they're trying to decide which version of radiation to go with, and maybe there's different options matched up with them, how it really plays out?
Well, first and foremost, you want to have the device or the treatment that your physician is familiar with, because there is a little bit of skill putting these things in place. And the more experience, the less likely to have problems. The Barrigel is more deformable, as we mentioned earlier, and doctors may have to take some precautions in ensuring that the pillow that was created remains stable, but they may have to adjust their targeting. For men that have had previous radiation, some of these people will have scar tissue, and scar tissue is more brittle. So if you go in and you start expanding and pushing on things, you can get something that will not deform as easily. And it's possible the Barrigel will sort of fit in more easily than the spacer. Remember, the spacer has to be injected in a very smooth, quick injection. So if there's concerns about the fragility of the rectal wall or after previous radiation, maybe the Barrigel might be a little bit better choice. It sounds like, in listening to people talk about this, that putting the Barrigel in might be a little easier for a beginner because it's put in slowly and you can kind of watch what you're doing. The spacer polymerizes very quickly. And the area that they're going to put it into is opened up with some water, but once it comes time to put the spacer in, it has to be done in one smooth push. This means that the doctor has to know what he's doing and have experience with it. If they do, then it should be fine. So these are very small differences. I think it's more important that the doctor you're using has experience with the device or the method that he's commonly using, and they all do function nicely in moving the rectal wall out of the radiation field.
So are all of these covered by Medicare and usually private PPOs or HMOs?
It's possible that an HMO might cover it. PPOs and Medicare typically are covering these things as they are FDA approved.
So one of the things that I find interesting is when you talk to different doctors who are giving radiation, and maybe they're at these really large centers of excellence, sometimes they disagree that these barriers are needed or that they're beneficial. In fact, sometimes they have some negative things to say about them. And because patients are out there researching their options, if you find some big expert coming in and saying that this isn't needed or it's a negative thing, it can be quite confusing and sometimes contradictory. And this is something that we see patients have to deal with in the midst of choosing a treatment and trying to decide. Then you have opposing opinions. So why would some big influencers when it comes to radiation in the prostate field have some negative comments regarding these barriers?
Not entirely sure. I mean, it's possible that in the learning curve, they've observed people who've had untoward effects. Doctors that are giving the treatment sometimes are not monitoring the people after treatment. Sometimes they go back to their urologist, and the urologist is the one that notices that, hey, there's proctitis here. And they're not calling the radiation therapist back because what can the radiation therapist do? They can't do anything about it. What's done is done. Those are some potential explanations, but people have wide and varying opinions about a lot of treatments, and I've run into, dissenting voices with just about every treatment option that I've ever heard of.
Regarding your patients, you've seen patients get these barriers and they've done quite well. How many patients do you think from your practice you've seen have these, different placers put in?
Hundreds. Of course, we don't give radiation ourselves. We refer to outside radiation therapists whose policies are to use these in everybody. And oftentimes, I'm not even having a conversation. When they were new, it was like kind of exciting, a new development that offered a lower risk of proctitis, which is, I think, just a devastating thing when it happens. But now that it's just become a routine part of daily practice, oftentimes it doesn't even come up in conversation. I'm sure the radiation therapists are talking to their patients about it before this is what we're doing and this is why. I no longer am spending a lot of time talking to patients about this methodology as it's become rather routine.
Through my career, I have met hundreds of prostate cancer patients, and I've even had the honor of being friends with a lot of them. And when I meet patients who have been through radiation burns and they have that as a permanent, lifelong, daily side effect from this radiation that they can never forget, their quality of life is affected tremendously. And you may say, well, it's only maybe 2% that you may get it. Well, the 2% is really big if you are that patient. And so you may hear some counter arguments to these spacers and these gels and the balloon, but I think it's just a good opportunity to have this conversation with your doctor. And if they don't want you to have it or they don't believe in it, just make sure you know why. Make sure that you are really prioritizing your quality of life. You're looking at the outcomes of the center. You're looking at the outcomes of the doctor. You're reading the reviews online. You're seeing how much experience that treating physician has. How many have they done? How many radiation burns have they had if they're choosing not to use these spacers? And what are the outcomes of the patients? Are there any patients you can talk to? Whether or not you're getting a spacer in any treatment that you decide upon, you should be asking these questions because it's important to know the outcome and the quality of the treatment that you're getting. We want to make sure that you're holding your quality of life as equal and as important to the treatment that you're getting and hopefully eradicating the cancer, because we want to make sure that you're not suffering greatly after choosing a treatment for the rest of your life. And if you do encounter people who are kind of contradicting, it's always important to get second, even third opinions, and to be able to have options and to weigh them if you do have that opportunity. If you are in an HMO setting, sometimes you can talk to a different doctor of the same field within that practice. You may be even going to a different center, maybe it's a different Kaiser location or whatever type of HMO you have. But I think it is important to fight for your options. This entire channel is about promoting effective prostate cancer treatments as far as awareness and education goes, but also promoting your quality of life and that you're important, that the care that you get after you have the treatment is there, that you're taking care of your emotional health, your mental health, getting your questions answered. All of this is extremely important. We want you to remember that you are important, the care that you receive during, before, after, and the quality of life is just something that you're paying attention to. And the reason we, talk about it so much is because we see patients where quality of life wasn't even talked about. It wasn't an option. And it's important that you really prioritize that, but you also advocate for yourself in these medical visits. Sometimes you have a short amount of time to get your questions in. So if you need help kind of figuring out what your questions are, figuring out what your priorities are, I would talk to our helpline. There are prostate cancer patients who have been through this. They've been trained by our medical oncology team, and they can give you some really great information. It's not advice, but it helps you get ready with your medical team to really go in, ask the right questions, get the information that you need, and it also helps you take care of your emotional health and mental health so that you can feel prepared for these appointments. Now, if you need more information, you can visit our website at pcri.org and subscribe to this YouTube channel because we come out with new prostate cancer videos every week. But I want you to remember, most of all, you're not alone, and I hope you have a great week.